Good afternoon once again.
Good afternoon.
Thank you so much for joining us this afternoon for this webinar. My name is Dr. Aghanya Nonso,
I'm Dr. Agbai and Hilda.
and two of us we are here to present gestational diabetes for you today, or what we call diabetes in pregnancy. So by the end of this discussion today, you understand what is diabetes in pregnancy, gestational diabetes, how to manage, how to diagnose and identify gestational diabetes, and at the same time, how to manage gestational diabetes to prevent the possible complication both the mother and the child will come with. At the end of this, you also know those people that have gestational diabetes, those are prone to having full-blown type 2 diabetes mellitus. So thank you so much. Like I said, my name is Dr. Aghanya Nonso, and with me here is Dr. Hilda. Yes, I'm a consultant physician endocrinologist.
I'm a medical officer.
So thank you. We are more than 70 now, so we can start. So today we are going to start in this following outline: introduction, definition, prevalence, risk of GDM, risk factors for GDM, that's gestational diabetes, the pathophysiology of gestational diabetes, diagnostic criteria, effects of DM on pregnancy, then management, and then conclusion. So with that,
So diabetes mellitus in general is a medical metabolic disorder of multiple etiologies, that's multiple causes, characterized by chronic hyperglycemia with disturbances of carbohydrates, fats, and protein metabolism due to impairment of insulin secretion, insulin action, or both.
yeah, thank you very much. What she's trying to say is that diabetes, like, what everybody will say is disease of sugar. But what we're trying to say here is that diabetes is not just about sugar. It's also about carbohydrates, fats, and proteins too, different food components. And it's as a result of insulin secretion problem or the action of insulin. I was trying to say. So
And this diabetes mellitus can be divided into multiple classifications. There's the type 1 diabetes, which is the one that we call the insulin dependent one. There's type 2 diabetes as well, which is the insulin non-dependent. Then there's the hybrid form. There are other specific ones. Then there also have ones that are unclassified, which means we cannot really fit them into either of the classifications. Then there's hyperglycemia first detected during pregnancy, which is our focus for today, where you have the diabetes mellitus in pregnancy, gestational diabetes mellitus.
all right, like my colleague here said, we have the type 1 who we commonly know, of course, in younger patients, which is total absolute insulin deficiency. We have the type 2, which is that of insulin resistance at initial stage, over time, total insulin deficiency. Now you have the hybrid form. Actually, more of fact, this is the WHO 2019 classification. If in case you have not seen it before it used to be 4 types, but now there are 6 types. So this hybrid form contains 2 types of classification. One, the latent onset diabetes of adults. It used to be type 1.5 before. It looks like type 1, but there are no ketones in urine. Also, we have the ketosis-prone diabetes, or what we call the flatbush diabetes, which looks like type 2, but they are ketosis-prone, very quite not like type 2. Other specific types are like it used to be type 3 before, whereby you have different classifications: genetic abnormality of beta cell, that's the MODY. We have insulin action, Rabin-Mendenhall syndrome. We have other conditions like problem with the pancreas. It can be pancreatitis, pancreatectomy, other hormonal involvement, like Cushing's, growth hormone excess, thyroid abnormalities. The non-classified type is the type that when you must have ruled out other causes of diabetes, you can't place it anywhere. You can call it unclassified. You can call it unclassified, sorry. So from today, if you're confused about diabetes, you can always place it unclassified. Nobody will query you on that. Now, like she said, hyperglycemia first detected during pregnancy is our major concern for today, which is diabetes related to pregnancy and gestational diabetes, with emphasis on gestational diabetes today.
So gestational diabetes mellitus is one of the most common medical conditions in pregnancy. It's associated with an increased risk of maternal and infant short and long-term ill health. There's a lack of international uniformity in the approach to the screening and diagnosis of gestational diabetes mellitus.
Yes, when they say lack of international uniformity, because the American Diabetic Association, they have their own, the Canadians, they have their own, the WHO have their own, the HOPA, everybody have their own. Then in Nigeria, we also have our own. But in the end, we try to synergistically bring in the positives and now reach something. So in case you are following the American Diabetic Association, you have no problem. You are following International Association of Diabetic and Pregnancy Study Group, there's no issue. WHO, but what we want is one that is going to be simple to be able to manage our patients very effectively.
The gestational diabetes has classically been defined as any degree of glucose intolerance first detected during pregnancy. Recently, the American Diabetes Association, that's ADA, defined it as diabetes diagnosed in the second or third trimester of pregnancy that is not clearly overt diabetes. However, some other associations, that's the International Association of Diabetes and Pregnancy Study Groups, their criteria says that women can be diagnosed to have gestational diabetes if fasting plasma glucose is greater than or equal to 5.1 millimoles, or if you're using milligram per dl, that's 92, but less than 7 millimoles per liter, or 126 milligram per dl.
Okay, so now that's what we're talking about, the uniformity. From the IDA-PSG classification, a patient that has 5.1 is diabetic. Sorry, has gestational diabetes. While in WHO, you must get to 7.0. That's what we're talking about here. So now, using WHO, for instance, a patient that has 6.7 is not gestational diabetes. Meanwhile, the IAD-PSG is telling us at 5.1 that a patient is having gestational diabetes, first detected in pregnancy. But any patient that has been diabetic prior to conceiving and along the line is diabetic, that one is a pre-gestational diabetes. That is diabetes prior to the pregnancy. That's not gestational diabetes. So that's how to actually differentiate. Someone that's diabetic that became pregnant is different from gestational diabetes. Gestational diabetes, there's no history of diabetes in this patient initially, and usually occurs towards the later part of the pregnancy, like I said, second and third trimester of the pregnancy.
So the prevalence of gestational diabetes, it varies widely from 1 to 28%, depending on the population study. There's a screening method as well and the diagnostic criteria, just like you mentioned in the previous slide. So the International Diabetes Federation estimated that in 2019, that 223 million women between the years of 20 to 79 years were living with diabetes. And this number is projected to increase to 343 million by 2045. So 20 million or 16% of live births had some form of hyperglycemia in pregnancy. And an estimated 84%, that's 1 in 6 births, were due to gestational diabetes. Most cases of hyperglycemia in pregnancy were in low and middle income countries, whereas where access to maternal care is often limited.
Okay. From the numbers we have here, you see that the numbers are increasing as the days go by. And there's a projection of 343 million pregnant, not even just diabetic people, pregnant, gestational diabetes, sorry. and it is usually high in low and middle income countries. And Nigeria, I'm sure we are supposed to be in the low. I don't know if you are in middle now. I don't know. Is it low or middle? Middle income countries. I know that we are low. But that being said, in Nigeria, we have a prevalence showing work done by Aziza and Negoke, 11% of Nigeria, Northwest having 13%, Northeast 11%, North Central 16%, Southwest 11%, Southeast 12%, and South 7%. But the funny thing is that in normal diabetes, South has the highest prevalence, but for gestational, they have the lowest. So from this record by Professor Aziz, the North Central has the highest level of prevalence. That is including Abuja of gestational diabetes. So what we are saying, you should be in the lookout for such conditions, know what to do, and at the same time know when to refer and where to refer this patient for expert management and good outcome.
So what are the risk factors for gestational diabetes? There is the family history of diabetes in a first degree relative, a sibling or a parent. There's also women who have given birth to large infants, that's children weighing greater than 4 kg. There's also history of recurrent fetal loss, that's miscarriages, age greater than 25 years, past history of glucose intolerance or diabetes in a previous pregnancy, and also polycystic ovarian syndrome.
Okay, like you said, it's very clear. So when you're taking a history of pregnant patients, please always go back and ask these questions. If there's family history of diabetes, that gives you an insight of what you're looking at. And patient with polycystic ovarian syndrome, it's syndrome of androgen excess, whereby they have cystic ovary with menstrual irregularities. This brings about insulin resistance. So when they get pregnant, there's a high probability that patient will have gestational diabetes. So it's a risk factor. We're not saying they are absolute things, they're a risk factor that possibly will throw the patient into this thing. We have more risk factors.
There's the obesity of women that are overweight, greater than 15% of non-pregnant ideal body weight. There's the ethnic group with a high prevalence of diabetes. You can see it in Asians, Hispanics. There's also history of stillbirth, unexplained neonatal death, congenital malformations, prematurity, history of preeclampsia or polyhydramnios, chronic hypertension, history of traumatic delivery with an associated neurologic disorder in the infant.
Okay, so these are the risk factors we should look out when a patient comes in pregnant prior to developing gestational diabetes. When you have all this, gives you an insight that this patient probably might come down with gestational diabetes. Someone that will tell that before that the father was admitted for diabetic crisis 2 times, the mother was. So these are things you get to hear from these patients. It points towards there's a possibility or predisposing factor that this patient might come down with gestational diabetes. So that it won't come to you like a surprise because, like I said, the mother is at risk, the fetus is at risk. Why is different is that for pre-gestational diabetes, people that have that before pregnancy, they already know, and they always tell their doctor that they are diabetic and look at the way it is. But these people might not even know because they say that's not in our family and Nigerian balance is not our portion, and God forbid. These are things our patients always come up with. And unfortunately, they might have this condition and they might be ignorant about it. So always ask these questions. Look out for these risk factors in these patients when they are seeing pregnant women.
So what is the pathophysiology of this condition? It's caused by placental production of human placental lactogen, HPL, and progesterone. There are other hormones that may contribute as well, such as prolactin and cortisol. So early in pregnancy, relatively higher levels of estrogen enhances insulin sensitivity. So as the placenta develops, estrogen decreases as HPL and the progesterone rises, resulting in an increased insulin resistance at the end organs level. So insulin resistance is most marked in the 24th to 28th weeks, which is why we talked about second and third trimester earlier. So which is the time when most women come down with gestational diabetes.
Okay, like you said, this is the major issue. The major culprit in gestational diabetes is the HPA, human personal lactogen. And as you all know, it comes up or is produced by the placenta. Now, the irony of the whole thing is that initially, when there's fertilization, there's formation of the embryo, the estrogen initially takes control, and it causes very good insulin sensitivity. But by the time there's implantation and we have the placenta formed, that's where the problem starts. Human personal lactogen comes up and gives serious insulin resistance. The resistance that it becomes so high that this patient's blood glucose gets so high. And when it gets so high, it affects a whole lot of things. The only difference now in gestational diabetes is that most times the embryo or the fetus already been formed. So the problem of malformation is out of the way because the fetus already been formed at this point. But now the major issue we have in this place is when there is this resistance, there's hyperglycemia in the mother, which obviously causes hyperglycemia in the fetus. The fetus on the own part, what it does now to increase insulin production to match the new environment of the hyperglycemia. This insulin production for the fetus, as you all know, has the same molecular component with insulin growth factor, which is an intermediary of growth hormones. As you can remember, the growth hormone works through an intermediary called somatomedin or insulin growth factor. And these growth factors have receptors, most especially in the fats deposits in the body. So now what happens? The hyperinsulinemia created by the insulin resistance in the mother causes hyperinsulin production. So hyperglycemia, sorry, that is created by this insulin resistance, causes high glucose in the fetus. On its own part, the fetal beta cell produces excess insulin. This excess insulin attaches to these insulin growth receptors, most especially in the fat deposits, causing increased deposition of fat and giving you that macrosomic baby. That's what happens in this place. So now, if you're managing this patient, you're trying to reduce this excess growth in this patient at the same time to reduce the possible complications that can come out from this. So the pathophysiology of gestational diabetes basically is insulin resistance and is as a result of the human personal lactogen. We have other hormones that can counter the effect of insulin, like the growth hormone, cortisol, that come into play, prolactin, they come into play, somehow accentuating the effect of the HPL. But the major culprit there is human placental lactogen that is produced by the placenta. That is why when these patients deliver and the placenta is removed, because not produced by the body, the blood glucose the resistance is lost in most patients and patient goes back to normal. Please, I want to remind us that by the end of this presentation, we have one or two case scenarios to go through so that let's test our level of understanding of this topic. So that is basically the pathophysiology. That being said, we get to the risk factors. For patients, how to test these patients, the people that have the risk factors for GDM. Those that can test at 24 weeks and those that you can test at booking. Now, this, like I said, is from the history what the patient is presenting with, like those risk factors we talked about. There's some risk factors the patient will present with. We tell the patient at 24 weeks, when we are sure the HPL will have been high enough to cause resistance, we do the OGTT for them, as oral glucose tolerance test for them. And also, there's some history you will get. You will have to do the OGTT at booking. Now repeat it at 24 weeks. So
the history that you get that will make you know that once it's 24 to 28 weeks, you have to do the OGTT is the first degree relatives with diabetes, the BMI, that's those that are overweight or obese, greater than 30 kg per meter square. History of polycystic ovarian syndrome, previous macrosomic babies, that's those weighing less than 4.5 kg or 4. So, and also the prevalence as well, like the race, the South Asians, the Middle Eastern. So while the risk factor that you get, I mean that you have to do the OGTT and picking and then repeat it again, is previous history of GDM, like Usuria, then a higher BMI of 45 kg.
Greater than the 30. So when you have such patient with previous GDM, you don't have to wait 24 to 28 weeks because patient might even be having overt diabetes. You must do the OGTT at the presentation. So this is a table of whom to screen. So you have the low risk, no screening.
So there's the low risk, there's the average risk, and then there's the high risk. So the low risk, you don't need to screen, which means you don't need to do the oral glucose tolerance test. While the average risk, you need to do the test at 24 to 28 weeks. And then the high risk, you need to do it as soon as possible, which are those you need to do at booking, at first contact. So for the low risk, we have the age less than 25 years and weight normal before pregnancy. Essentially, people that you don't have those risk factors that we've talked about. So no known diabetes in the first degree relatives, no history of abnormal glucose tolerance, no history of poor obstetric outcome in previous pregnancies. So those that have the average risk are the overweight women, those in the high risk race that we mentioned, the Asians, the Hispanics, history of stillbirth, unexplained neonatal death, prematurity, history of preeclampsia or polyhydramnios, chronic hypertension, recurrent severe candidiasis or urinary tract infection, history of traumatic delivery with an associated neurologic disorder in the infant. Then those with high risk, marked obesity, prior gestational diabetes, glycosuria, strong family history, or ethnic group with high diabetes prevalence.
So, like you said, these are the people you must screen, and those that you probably might not want to screen. What you do is to watch them, observe them, and now know when to screen. But if anybody falls into the group that's supposed to be screened, please, let's not waste time. Let's screen so that we can start management immediately. Because like we said, the mother is at risk, the fetus is at risk.
So how do you make a diagnosis of gestational diabetes? So hyperglycemia associated pregnancy outcome study changed everything about hypoglycemia in pregnancy. According to the IADPSG, the proposal in 2010, which was adopted by WHO, and also the American Diabetes Association and International Diabetes Foundation, the risk-based screening, there's a risk-based screening versus the universal screening, and which involves using the 50-gram to 50 gram over 100 gram versus the 75 gram glucose challenge test.
Yes. So what I'm trying to say here is that you have to making diagnosis, you need values. But for those values, you need to challenge the pancreas, what you call pancreatic function test. Now, in as much as there are controversies, in the end, it was realized that IDPSG overruled all the WHO, ADA, and IDF, which everybody is tilting towards. So now, why actually left the risk screening and universal screening, not what you used to do before, whereby you do two-step, 50 gram, 100 gram, and stressing the patient. Now, the simple glucose challenge test, OGTT, 75 gram, and it's just for 48 hours, not whereby you give a patient 50 gram initially. But these are things people used to do, and some people still do it. Like from the American Congress of ONG, they are still doing it, but we don't do that again. We do the simple one-step 75 gram OGTT in this patient, and it has been endorsed by WHO, IDF, and every other person. So it's a very simple system whereby you give a patient 75 grams of glucose, but before then you take the baseline of this patient, then you take after 1 hour, then after 2 hours. It's very simple. It's not something that is cumbersome. The person is fasted, give glucose, and then you read all these things. Just challenge, read all the results by 0, 1, and 2 hours, just challenging the pancreas, and that gives you the results you want to. So when you do all these things, there's some values you get at that point. You know that this is gestational diabetes. Now, when you have a fasting plasma glucose of 5.1, or greater than 5.2, 1 and above, or 7.0 and above, what it means is gestational diabetes, according to IDA, PSG, and WHO. 1 hour post 5 gram greater than 10 is gestational diabetes, according to IDA, PSG. But for WHO, we don't do 1 hour, just only 2 hours. Then 2 hours, 75 gram is at 8.5 is gestational diabetes, then 7.78 for WHO. Any of these readings, just one of these readings, taken at 24 from 24 weeks of gestation is gestational diabetes. You don't have to wait for it to be 2 or 3. Just one of these readings is gestational diabetes. That's what we want to establish today. So when you have a patient in your clinic, probably 26 weeks or 32 weeks, you do a fasting blood sugar and it is 5.2. That person has gestational diabetes. 1 hour of 10.5 is gestational diabetes. And 2 hours of 8.7 is gestational diabetes. So when you now have 10 points, 13 points, you don't have to be told what's happening. This is gestational diabetes. So this is a graph of the same thing I'm talking about. The IDPSG is still there. The old ADA, they will have 3 hours in their own. Then WHO, like I said, just at fasting and just 2 hours. Another guideline, like I said, due to the controversy of the American College of Gynecologists, they have their own. The Canadian Diabetes Association, they have their own. WHO, they have their own. But in all this thing, what we normally use, or what we use, basically is the IDA-PSG. And one value is sufficient for you to make a diagnosis of gestational diabetes in this patient. So then for now, for these values, these are people that are diabetic before pregnancy. So if someone presenting to you that some reasons, and don't worry, we'll give you time to ask your question. There's no problem. We'll give you time. We entertain the questions, then we'll also ask our own questions. So for okay, diabetes in pregnancy, the fasting will be a fasting of greater than 7.0, like the way you diagnose normal diabetes in patients. 2 hours 11.1, and then random blood sugar of 11.1 and HbA1c of 6.5 at any before 24 weeks of this patient is pregestational diabetes, and diabetes in pregnancy. So this one is, so if you have a patient at 2nd month or 3rd week coming with fasting of greater than 7.0, please, it's sorry, diabetes in pregnancy, pregestational diabetes, please.
So what are the effects of the gestational diabetes on the baby? We talked about earlier how it causes harm to both the infant and the mother. So for the infant, you have prematurity, being born before the due date, fetal macrosomia, birth trauma, stillbirth, transient neonatal morbidity, neonatal death, obesity, and or diabetes later in the child's life.
Okay, as we talked about fetal macrosomia, how it occurs, the birth trauma from the birth, basically. So
these are the effects of the diabetes on the mother's health.
Yeah.
So you have preeclampsia, it affects 10 to 25% of all pregnant women with GDM. There's infection, high incidence of cranial meningitis and postpartum endometritis. There's postpartum bleeding. There's cesarean section, more common due to the fetal macrosomia and cephalopelvic disproportion. There's weight gain, hypertension, miscarriages, long-term risk of type 2 diabetes mellitus.
Yeah, so like we said, the mother is at risk, the baby is at risk. So getting or identifying gestational diabetes on time and maintaining good treatment will help us prevent all these possible outcomes in these patients.
So how do you manage? What is the principle? What do we do? The goal is to prevent adverse pregnancy outcome, like you mentioned, and then it involves a multidisciplinary approach, which involves the consultant obstetrician, the diabetes specialist midwives, the diabetes specialist nurses, the dietitian as well. And the patient is seen every
And diabetologist. And
and the
diabetologist.
diabetologist.
Yeah, you are the
The
profession
patient,
would mix.
the patient is seen every 1 to 2 weeks until 36 weeks gestation and then weekly. And then the patient is asked to keep an accurate diary of their blood sugar glucose check.
Yes. She said is multidisciplinary approach with the diabetologists, then liaising with the obstetrician and the midwives that have experience in diabetes, also specialist nurses. Now, these visits can be done 2 weekly before, depending on the patient's convenience, until 36 weeks, after which it is a weekly visit. And this weekly visit, patients will keep record of their daily blood glucose, because that's what you're going to go through and see if you have a good glycemic control and how to adjust whatever you're giving the patient. So with that, it gives you an insight. In cases you are confused on what to do or how to interpret, ask the patient to do the blood glucose morning, afternoon, and night. It's going to help you. It gives you an insight of what the patient, how the patient's feeling is like. So you can be able to counsel the patient and understand, and even understand that these things affect the blood glucose. And it also helps you adjust what you're giving the patient to suit the patient's lifestyle. The problem with gestational diabetes is not just, normal diabetes. The patient might just want to go out of the way and eat what does not want to eat. But the gestational diabetes, these women have cravings too, and what they want to eat, what pregnancy does to them. So you can imagine trying to control what she wants to eat and what she's craving for. They'll get out of that feeling at that point. So you need to actually counsel this patient, make them understand the need for them to be very, very listening to what they are doing in terms of feeding and satisfying their cravings.
So gestational diabetes advice initially starts with change in diet and increasing exercise. So we don't just go straight to medication. We start with lifestyle adjustments. And if the blood glucose is not controlled with this, then we can now start the medical therapy using drugs. So and start with metformin or insulin.
Okay, now, like you said, dietary medical therapy is the first thing we do for diabetic patients, whether gestational or type 2 DM patients. So we try the much we can to make the patient adjust the feeding pattern, and at the same time encourage the person to do exercise. Exercise is not serious, not going to carry weights. Can do 6 minutes walk in the closed environment. It's not a matter of trying to train as if you are going to Olympics. No. This is pregnant, and so we need some level of exercise, because exercise increases insulin sensitivity. And what does it do? It stimulates transport of what do you call it? Production of with that increases glucose absorption in the muscle. So it is encouraging these patients and then diet. But at the same time, these things alone will not be able to control this glucose. That's why you should be looking out for their daily checks of blood glucose. If you're not having control, let's move to pharmacology therapy, which can be insulin or other medication, depending on the one you want to use for the patients.
So the cornerstone in the gestational diabetes management involves counseling the mother about the maternal fetal complications. So they need to understand what is at stake to ensure their adherence. There's the medical nutrition therapy, glycemic monitoring, teach the women how to check their glucose themselves and the targets that you want. The fetal monitoring using ultrasound, planning of delivery, long-term risk.
Okay, so I'm very concerned about the third point here. I tell anybody that's managing a diabetic patient, that diabetic patient must not will or can or might, it must have a glucometer, because self-monitoring of blood glucose is what we are yearning for as the intake, whereby a patient knows what the blood glucose is at a particular time compared with what he's feeling at a particular time. You cannot be feeling tired, weak, hungry, and you have a glucometer, you check. You check yourself immediately now. You don't assume probably sugar is low or probably sugar is high. It doesn't have probability because each one has a problem. Hypoglycemia is leather. Hyperglycemia, bad, but can be managed. Hypo, very leather. So these patients must have a glucometer for self-monitoring of blood glucose. That being said, you make them understand the implication and the complication they can have in GDM so that they can monitor what they are eating. Because if you don't make them understand that this thing can affect the baby, can affect you, they will understand the possible outcome. Medical nutrition therapy will be easier for them so they can now watch what they are eating. And at the same time, the fetus should be monitored too. Then delivery should also be planned to avoid all these risks coming up.
For the dietary therapy, we start with referring to the dietitian, the way they recommend a complex, high fiber, carbohydrate diet, avoid concentrated sweets.
Okay, please always refer to a dietitian. This particular case, I told you we are dealing with a whole lot of things, not just a diabetic patient that wants to eat anything. It's a pregnant woman that has craving for a lot of things. Some might not have, but most people have cravings for things. And most times, they're always sweet things they want to take. So you can imagine where you're fighting to bring down the blood glucose and the person is trying so hard to satisfy a particular craving that will cause the glucose to go high. So in such people, they say recommend complex high fiber. No problem, recommend that, but they make sure that these people or this person sees a dietitian for proper counseling and how to adjust their feeding. For sweet things, they should totally be out of the table if they can. They have to force them because it's going to be difficult. Most patients, they tell you no problem. When they go home, they do what they want to do and say this life only once. So those things are things we need to educate, disabuse those thoughts, and make them understand that really we can do this. It's not by shouting, no, please. You have to make them understand that these things are not things that cannot be done. That's been done by so many people and they do well. So make them understand we can work around these things and make these things happen. So this is the glycemic level we expect in gestational diabetes. Why I put this in red is I understand that this one is different from normal type 2 DMO. Very, very different. For the fasting blood glucose is between 4.0 to 5.1. For 1 hour postprandial, 4.0 to 7.8. For 2 hours postprandial, 4.0 to 6.7. Now, this one is actually a very tight glycemic control. To tell you, the level of abortion in gestational diabetes and diabetes pregnancy is so high that when the glucose goes up, there's the way the abortion occurs, you can't even imagine it. In terms of experience, it's so high in the sense that this blood, when you go as high as 11, 12 in pregnant women, the chances of abortion is so high that the patients lose their pregnancies. So now this control is supposed to be a very tight control. Yes, it's tight. When I mean tight, so that we avoid any complication. So it's not just telling a patient about food, or she needs to understand that you don't need some things and you need to make some things to be this way. So that by the exercise you talked about, the diet modification, then taking her drugs regularly. This is what we're emphasizing today. So please, if you don't go away with anything, make sure you go away with these values. These values are what we are looking at. These values are values we want to maintain this patient on. It's going to be difficult, but it is very good. We've done it so many times, but at the same time, we have to be ready to do it. Please.
So when dietary therapy fails, like you said, we always start with that. Then we move to pharmacological therapy, where you have the insulin, we use rapid acting insulin analogs like Aspart, Lispro, NPH, long acting insulin, Picamide, Glargine. There's the oral hypoglycemic agents as well, using metformin, glyburide. Due to the efficacy and safety concerns, the ADA does not recommend oral anti-hyperglycemic agents for gestational diabetes mellitus or pre-existing type 2 DM.
Okay, so like you said, by the time you're taking care of the feeding and exercise, and the control is not there, you have to enter pharmacologic therapy. So, like I said, depending on what you want to use. First of all, in my own practice, insulin comes first. Why? First of all, insulin does not cross the placenta. That is the safety of it. So it does not affect the milieu of the fetus. So why is it this way? It only takes care of the mother, makes the blood glucose to come down, and the blood glucose is of the mother is a reflection of what the baby is going to have. So when you manage the mother, obviously you don't have a problem with the baby. That's the problem. That is the beauty of insulin and why I was advocating insulin. Now you have different forms of insulin you can use. You have the aspirin, the lispro, that is short, rapid acting insulin, MPH and intermediate acting. So now, but the thing is, for this rapid acting, they need very close monitoring because they can easily tilt the patient into hypoglycemia. So patients in the ward, they have a problem with that. But starting a pregnant woman with rapid acting insulin, you need to be very, very careful because there's situations of hypoglycemia. The long acting ones have been studied, especially the Temia, that can be used for pregnant women. Yes, they can work. They are long acting insulin, as up to 24 hours of the day. They do not peak. They form crystal under the subcute surfaces, so they can make them last for up to 24 hours. So it is advised that patients should be on this. But now, for the OHAs, especially metformin, some studies have shown that 10 to 16% of metformin can cross the placenta, which is a problem. But at the same time, some studies, glucophage in pregnancy study, said there's nothing like that. So now there's a lot of controversy. Which one to use, which one to bring in. There are situations whereby, like I said, they're not cast on stone things. Each patient is individualized, what works for this patient. As a patient that will be on basal bolus insulin to be sure that glucose is controlled. There's a patient that will be on just once a day insulin. But they have so many controversies they have to bring into play. So now, if there's need for you to use metformin, you can use metformin. Like I said, it has its own pitfalls. But some people, like the ADA, they don't support the use of metformin in gestational diabetes. Probably, I think, because of level of communication with the placenta, that was that thing. But if there's need for you to bring in metformin, you can bring in metformin. There's no study that has shown it's actually teratogenic. But there's no study that has shown us that it is not teratogenic. So it's like being on the fence. So, like I said, you make your choice. But now there's some people that now there are some environments that they cannot even be able to have access to insulin for this patient. It is meant for me. And patients do well. But if you should ask me, you have an option of insulin and metformin or bread, I will simply go for insulin. So what I'm saying today is, even the patient is on AHA and tells he's pregnant, stop the OHA immediately and convert the patient to insulin. Monitor the insulin, monitor the blood glucose. At least it needs to give you at least three readings in a day. If you can afford more, you can do more. You can increase the number of checks in a day. So with that, you will be able to have a good control of blood glucose in these patients. So now this is an algorithm of what I was talking about. A patient presents to you, you're thinking of gestational diabetes. The first one, diabetes of gestational diabetes, you have made it, you have done your fasting, 24 weeks is 5.2, 5.3, the other one, 10 point something or 11. So now it means you have passed stage 1. Stage 2 is lifestyle modification for all, which allow everybody to improve the lifestyle, so-called medical nutrition therapy, exercise, cell monitoring of blood glucose. That is there therapy for dietitian, exercise, especially post-meal, cell monitoring of blood glucose. Now, with this, you expect some level of changes and improvement in patient blood glucose. But it's not reached, you go to 3A, consider pharmacologic option. But if it's reached, you now continue monitoring the patient cell monitoring of blood glucose until patient delivers. But now, if not reached, you start counsel the patient on insulin therapy. Most times, starting patient on insulin in Nigeria is a very big feat. You have to preach, beg, even cry yourself, because you know this patient is going down. They're telling you that they told them that if you start insulin, your own is finished. I will now ask you, you already finished. So why, what is it? Why don't you try and bring it out of that finishing part? That's what I always say. Because this belief in Nigeria that if you take insulin, your own case is just, I don't know how to explain it. I don't know where that mentality is. The only time a patient takes insulin is when they carry that patient unconscious and comes in, you start to start telling the patient, no problem, you will follow the insulin. But immediately he gets up and wants to go, say, please, I don't want insulin. Something that kept you alive. So, the whole thing, I can't wrap my head around it. So, agreeable to insulin is very, very important, because if you don't agree, you're wasting your time. But most times, in pregnant women, I think they love their pregnancy so much, they don't really query using insulin. But if you see someone that is normal without any issue, I mean, any pregnancy, normal diabetes patient, starting insulin, both male and female, is a big problem. But it's okay. We keep on begging. And I'm asking you today, always beg them, assure them that it's the best thing that can happen to them so that a good outcome will be reached. So if patient is not agreeable to insulin, insulin, beginning insulin, first line, based on hyperglycemia, now refer to specialist. Now, at the same time, if not agreeing to insulin, consider other therapy based on fasting or hyperglycemia, then high pre-pregnancy BMI or weight gain, history of PCOS, insulin resistance. So, other therapy for these patients start metformin for them. And then if there's no this thing, much control, they can giving the glyburide. It's a sulfonylurea too. So now, the main thing in this situation, like I said, if you can convince a patient to start insulin, all this long process of whether you start metformin or add anyone goes away. And we need to educate these people, please. There's no better one that is if you take this one, diabetes will go away. No, these are kind of things we hear. Unless pregnancy will not be diabetic. No, please. Let's always educate them. This education is very, 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 very pivotal in managing these patients. So all this said and done, if a patient agrees on all this, continue. Watch the blood glucose closely. Make sure you maintain 4 to 6.0 as control to avoid any complication coming up. After the delivery, you now decide what to do. Whether asking the patient to continue or to stop, which we're going to talk about also. So this at this point is more of ONG than internal medicine. Going to deliver, to induce labor, then effect elective CS. I think it's dependent on the weight of the patient. Because I think that it's 3,800 grams, 3.8 kg. They can do this thing. They can monitor the patient, there's no problem. So, but when you have from 3.8 to 4.0 kg, the baby is already large. You have to induce labor and try to maneuver it out. But when the baby is more than 4 grams, as 4.0 kg, elective CS is mandatory for these patients to avoid complications. So these are the delivery schematic for it.
For the postpartum care, after delivery, insulin injections or oral glucose lowering drugs should be stopped when the placenta is delivered. The blood glucose monitoring should continue for up to 24 to 72 hours to monitor pre-meal and post-meal.
So like I said, the placenta releases what causes resistance, that's the HPA. So when you bring it out, you stop the injection to avoid causing hypoglycemia in this patient. So you monitor and see if the blood glucose is still the same, going up or coming down. And you can do this thing next 72, even more than 72 hours, depending on what you have on ground at that time.
So, and for the baby, the postnatal care, we counsel on the symptoms of the hyperglycemia, the risk of the gestational diabetes in subsequent pregnancies, and the risk of developing type 2 DM for the mom. Breastfeeding helps in weight loss, lifestyle modification, exercise, weight reduction, and diet, preconception for the next pregnancy. Still on the postpartum care, to stop the blood glucose monitoring unless there is need. The HbA1c, check the HbA1c at 13 weeks, then oral glucose tolerance test at 6 weeks postpartum. This will help you to classify patients into the normal or impaired glucose tolerance and those who are diabetic. So on follow-up, if the patient's postpartum glucose tolerance is normal, she should be re-evaluated at the minimum of 3 years interval with a fasting glucose. All patients should be evaluated for glucose intolerance or DM before a subsequent pregnancy.
Okay, this is very important in managing your patient. By the time you have guided your patient, eventually patient delivers, you have to take care of the patient postpartum. What I mean by this is you have to do things to confirm if this patient is actually diabetic and or this patient has impaired glucose or patient is not even diabetic at all after the listing. So, like she said, things you need to do HbA1c at 13 weeks, then OGTT at 6 weeks postpartum. So that gives us insight. By that time, the resistance obviously must have gone if it's going, but if it still continues, it becomes clear to you that this person is already moved to full-blown type 2 DM. So that's all the way. Then for subsequent pregnancies, it should be cancelled to do OGTT before being pregnant. So this one, this can be used to follow up a patient because most times people don't know when someone has delivered. What do you do next? No, we have to do all these tests to be sure that this person is not this. You understand? So with that, we are sure we are taking care of the mother. And always remember that if the OGTT is normal and the woman goes away, that after 3 months, after 3 years, sorry, patient is supposed to be reevaluated. But unfortunately, most times, for 3 years, patient is pregnant again. So they're back. You start from the beginning. No, sorry. Fortunately, let me go unfortunately, sorry. Fortunately, the patient is pregnant again and you're back from the beginning. So most times the 3 years doesn't really work, unless probably the last pregnancy.
So who will progress to DM? Who are those that will end up still having full-blown type 2 DM even after pregnancy? So we have the auto antibodies, we have the BMI as well as the strongest predictors. Then the waist circumference. We have the DM at earlier gestational age, earlier than the 24 weeks or just around then. Then you have the gestational requirements of insulin, higher fasting blood glucose, higher blood glucose of OGTT, recurrent gestational diabetes.
So we should take note of all this because these are the pointers of people that might possibly go down with gestational diabetes when you're managing them. So casting them on time so that they make up their mind that this is a possibility. Because I'm sure they will tell them that when of pregnancy, you're okay. Oh, some people don't become okay. A percentage continues being diabetic. So that's the way essence of this. So when you see all this kind of presentation in the patient, please be rest assured that the patient most likely or most probably might be going into full-blown type 2 DM.
So in conclusion, Gestational diabetes is a common problem worldwide. This stratification and screening is essential in all pregnant women, particularly those with increased risk. The tight glycemic targets are required for optimal maternal and fetal outcome. Patient education is essential to meet these targets. Long-term follow-up of the mother and the baby is essential.
Yeah. So, like I've been saying since, it's a common worldwide problem. And we must maintain tight glycemic control to avoid maternal and fetal catastrophe. Patient education, like you said, is paramount. They need to be educated. They need to understand. Nobody is from village. Nobody is in a matter. It's just that gestational diabetes and I happen to you. Understand? So you need to have all this in mind. And with that, be able to present on time. And then who they are presenting to will know what to do immediately. And if in any pregnant gestational diabetes requires pharmacological therapy, please refer the person, if you're a specialist, refer to a specialist. Please. Send the patient down here, we'll take care of the patient. But like I said, you must do something first. Try and entertain the person. We'll talk about it. So that being said, I'm very, very sure people followed us. We have 120 people following us in the lecture. And just before we take questions, I think I have a scenario here that she will read, and I expect to see people write up what you feel. And they are simple case scenarios, life case scenarios, simple, and let's see what you feel about it.
So the first case is a 42-year-old businesswoman presented to the clinic at a gestational age of 27 weeks with a fasting blood sugar of 5.5 millimoles per liter. There is no previous history of macrosomic babies in the past two pregnancies. What is the diagnosis? What is the reason for the diagnosis?
So I wait for you to write. Let's see how you are thinking from the risk factors we talked about, from the diagnostic criteria we brought in, from the possible complications both the mother and the child can have. What do you feel this one is? Second one?
So the second one is a 37-year-old teacher presented to the gynae emergency at 14 weeks of gestation with a random blood glucose of 13 millimoles per liter. She has had two previous pregnancies carried to term. What other history would you be interested in taking to make a diagnosis, and what is your diagnosis?
Same thing. From my diagnosis criteria, these three, the possible diagnosis. So thank you once again for joining us. We have more than 120 people here, and I'm sure they must have learned one or two. So we have time for questions. You can chat your questions up. We'll address them one by one. That's why we are here. Please, clarifications, what to do, and then what not to do, please. Always know when to refer to a specialist. Always know when to refer to a specialist. I know where to send the specialist. The patients to see the specialist. So, you have free to just chat it up and let's see. And we go to, but at the same time, we have a question and we're expecting answers from you. So I think I'll be changing the questions. And let's see. She followed us very well. Is it? Okay. 2. Okay. Where is it? Okay. More. Okay. Okay. Okay, the first question is, please, at what gestational age should a diabetic woman who has been placed on exercise be asked to stop? Or should she continue exercise till time of delivery? Please, I want to understand what you mean by this exercise. Hope it's not running or carrying weights. Please, it's just simple walks. Those things, it helps in circulation and increasing insulin sensitivity. It's good for the mother and good for the baby. So when the patient feels she cannot do it again, it's okay for her. So it's a moderate intensity exercise. Please, not serious intensity exercise. So, sorry, you can't answer question when the chat box is closed. Okay, okay. Please use the Q&A, please, right? So diagnosis of, okay, number one, GDM, reason. What's EGA? Okay, look, it's not age. Okay, okay. Two, pre-positional reason, EGA is 13 weeks. Okay, that's anonymous attendee. We'll come to that. Please, is there an explanation for a sudden fetal demise that happens near term in patients? Okay, thank you so much for the question. He said, please, is there any explanation for the sudden fetal demise that happens near term in patients with GDM? Really, that's what we're talking about. The glucose control is very, very optimal. Initially, it needs to be very, very tight, not even optimal, sorry. At this point, from my own experience, you see situations whereby just a 2 millimole increase in that already stable glucose control brings about abortion. Really, outcome is so bad. But I want to assure you that if this control is tight, optimal, and maintained, nothing happens. That is the truth. Nothing happens. But unfortunately, whenever you have blood fluctuations up and down, I follow my patient up, I have to be calling you, I hope you are doing this, because most times you don't even understand what you are running from, no matter how you explain it to them. But you being the doctor, you have seen it firsthand, you have seen it most times, and you don't understand it the way it is. So, really, the glycemic control is usually a problem at that point, but patients still do well. How long do you observe glycemic control using lifestyle modification before we commence on because there's no longer. If the sugar is not controlled, please move to the next stage. If lifestyle and what do you call it, and dietary modification exercise is not controlling it, no waste of time. Please start pharmacologic treatment. There's no particular age. Thank you. Someone said case 2 is GDM. Okay. Stage GDM, reason age of the patient. Okay. Case 1, gestational diabetes based on age verification. Okay, 24 weeks. So case 1 is okay. You're correcting yourself now. Case 1, wait. I don't want to call name. I don't want to call name. You corrected yourself. GDM, what case with diabetes in pregnancy? We'll come to that. But you didn't give us reason. Please ask your question. Maybe I would have asked for a question first. Ask your own questions. Please, any clarification you want, anything that gives you problem in managing this patient so that you do something before you refer the patient. Anything that gives you problem, please. Ask your questions. We are here to answer it. For how long will the patient be placed on lifestyle modification before commencing medication? Please, there's no long. I said it before. These patients, if the lifestyle modification cannot control the blood glucose, please immediately start pharmacologic treatment. Immediately. For the slide, open the screen, please. Okay. Sorry. Okay. So, still waiting for your questions, clarification. Any mystery? Okay, yes, very important question. Very, very important question. How do you determine the dose of insulin to patient? Thank you so much for the question. Please, thank you so much for the question. Now, for the patients that you are seeing that is gravid, when I mean gravid, there's already advanced in weeks. Now, it's not like the normal patient you use 0.1, 0.3. Now, for this patient, you do 0.7 to 2 units per kg because you are factoring in the weight and everything of the baby. That's what you do. Now, for the long acting, you give once in a day. Now, for the short acting, depending on if patient is having back glycemic control, by patient is admitted, you divide, you give 2/3 of it in the morning, and now, sorry, 2/3 of it in TDS, and then 1/3 as long acting. Please. Now, for if a patient is not gravid, you can do a normal 0.1 to 0.3, depending on how the patient, not heavily gravid, depending on presentation, mostly diabetes in pregnancy. For those that are presenting at early age with gestational age with diabetes in pregnancy, can use a normal 0.1 to 0.3. There's no problem on that. For the long acting 0.3 times the patient's weight, you adjust according to patient's demand. But for those that are actually very gravid, you can use up to 0.7 to 2 units because they require high dose of insulin. Thank you for that question. It was an oversight. And okay, those were the oral. Okay, before then, please, sulfonylurea is safe in pregnancy. Like I said, according to ADA, there are some things they don't accept. Studies have shown that metformin, first of all, have some level of crossing of the placenta. But studies done by glucophage in pregnancy said it's a lie, so you don't know who to believe. Sulfonylurea too has no controversy around it, but we commonly use more of biguanides than the sulfonylureas. But from textbook is written there. But practicality, like I said, insulin, for me, insulin is really better to avoid any stories and touch. Yeah. What goes for the oral hypoglycemic? It can start from titrating and the much 500, 1 gram, depending on the patient's need. Okay, can you add the insulin calculation is done? Okay. On the slide is okay. We do that, but remember that insulin management is patient specific. Please, those that work for this person might not work for this other person, because there's a possibility that some people are naive in the sense that the insulin overacts, the other ones resistance is so high, no level of resistance. Thank you for the questions. Can you keep it coming? Are you had any case of hyperglycemia emergency in pregnancy as gestational? I think it's how do you manage such cases? It's a common finding now. They can have, it's a very, hyperglycemia emergency in pregnancy can occur. And you manage as you manage emergencies. That's what you do. The beauty of, like I said, the beauty of this whole thing is even if you give 20 units or 30 units of insulin, it does not affect the fetus directly. The only thing it does is to change the glycemic level of the mother. It doesn't cross over. So there's no fear. There's no fear of you give 40 units, you crossed over and made the fetus hypoglycemic, and you can't give them glucose. No, that's the only safety of using hypoglycemia. So you manage as emergency the way it comes. There's no problem. You hydrate the patient, give insulin therapy, correct the precipitants, and the patient is good to go. Which of the cutoff are we using, WHO or others, for the use of GDM? It's a serious question. Presently, what I use is International Journal of Diabetes and Parent Study Group, which the whole WHO, ADA, Canada came together. Why? Because general diabetes can be detected as early as 5.1. So you can imagine using 7.0 as a cutoff. The patient has been 6.6 for the past 3 months before that comes to 7. But most time, complication already happened. So it gave us an insight that we can get this diagnosis as early as possible and start treatment. For people with PCOS, we advise them to start anti-diabetic medications, preconception, as a risk of them becoming diabetic post-delivery. Okay, first of all, in PCOS, first of all, there's insulin resistance, first of all. So you should understand there's a problem with activity of insulin, and part of the treatment of this patient is metformin. And to start anti-diabetic preconception. No, we'll start preconception, please. In what I would say in this one is, when you say preconception, is person trying to conceive. If you're trying to conceive, you meet your doctor, you can always change all these things. But most times in Nigeria, most pregnancies are not planned. Let's say the woman misses her period and shows a test is positive. Now, what I say at this point, go and meet your doctor so you can adjust all these things for you. Or when they come to you, please stop the orders at that point and now start your insulin at that point. So the post-delivery, I don't know, it is when you do your OGTT at 6 weeks, I repeat the HbA1c. Some people, I've seen patients that had GDM, each pregnancy GDM, 4 of them, and they're not diabetic. I've seen someone that had GDM once and the manager for that, living with diabetes. Thank you so much for your questions. I don't know if anyone that's then back to our own question. Some people got, I think I want to will take of the questions. Some people actually got the answer, some derailed and went back and thought about it. Why I made the first one 5 points. Was it 5.3? And what was my 5.5? Yes, so that it will sound like it's a normal blood glucose to you. But according to the this thing, IDPSG, you see, this patient would have been missed in the diagnosis. And look at the gestational age, 27 weeks. That's at the peak of HPA production. And I purposely put this macrosomic babies, no previous history, to not to confuse you, to make you understand it very well, that some things might not be there and they make your diagnosis. So this was correct. 5.1 is our benchmark at IDPSG at 27 weeks. So with that, we are good with this one. Then the second question, a school teacher presented to gynae emergency at 14 weeks. Now, from the weeks, you know that we are not dealing with gestational diabetes, an RBS of 11 millimoles, and from our with an RBS. So with an RBS of 13 millimoles per liter. So From our own normal diabetic patients. Understand? This is 13.1, and it's more than our 11.1. So these other ones are things just to extract it. So now, which other history would you be interested in making a diagnosis of this patient? So which history might be? Nobody talked about this history. Which history might we be interested in making a diagnosis? Where's the Q&A? Okay. Okay, you're not diabetic? Yes. I've seen a question. Exactly. That's the question if you're non-diabetic before. Yes. That's a very simple question. No? And what again? Family history of diabetes? A person is non-diabetic, so history of macrosomia. I said she had 2 previous pregnancies carried to. Okay, okay. Yep, that's good. By and large, it's a very interesting outing, at least people are following. So from this question and answer, I'm sure that people are specialists in gestational diabetes now and can do good in saving the baby and the mother. So at this juncture, I think we have taken enough questions and clarifications. And thank you for being around. We have more than 110, and so far they've been very, very contributory. Thank you for attempting the questions. Thank you for listening. And thank you for the questions, and because it was very entertaining, and I'm sure we learned something today. Just before I go, hand over to my manager to tell you 1 or 2 things. How to locate us if you have gestational diabetes you cannot manage. How to locate us so can give the patient the best. But treatment starts from you. That is it. So thank you. My name is Dr. Aghanya, so like I said. Yeah. Thank you so much.
Okay, so thank you for joining me. Um, my name is James Emmanuel, and I will want to tell you about the services we offer here at Cardiocare Multispecialty Hospital. And this webinar was brought to you by Cardiocare Multispecialty Hospital. It happens twice every month, the second Friday of each month and the last Friday of each month. So something that you can attend regularly and to help your practice. So I'll just be going through what we do here at Cardiocare. So Cardiocare Multispecialty Hospital is a hospital that is dedicated to cardiac health. We are located at number 5 Giza Close, Area 11, Garki, Abuja. We are just 1 hour, 30 minutes away from wherever you are. And you can reach out to us. As you can see on your screen, there are some numbers on your screen. You can reach out to us through those numbers. And we won an award of cardiovascular excellence in the year 2021. So Cardiocare is a hospital that is focused on safety, effectiveness, patient-centeredness, and we work based on international standards. The services that we offer include cardiology, interventional cardiology, endocrinology, diabetology, nephrology, transplant and dialysis, neurology, rheumatology, pulmonology, and critical care. You can reach out to us for everything that pertains to internal medicine. We do them here in Cardiocare. We also do coronary angiography and interventions for patients presenting with chest pains and for those that need interventions in the aspect of peripheral angiography. We are open to that. We also do kidney transplant and dialysis. So we also do non-invasive assessments, which includes Holter, spirometry, stress EEG, and stress EEG and ECGs. You can reach out to us, and we are now doing cardiac thoracic surgeries. If you have patients that are in need of those services, you can reach out to us. So I'm talking on how to refer to us briefly. So if you have cases that you want to refer to us, what you just have to do is to send a referral letter. You can reach out to us on the sites that you can see that is on your screen. Send an email to frontdesk@cardiocare.ng or v.omotade@livinghospital.org, or you can also send to me. So you can also see our WhatsApp numbers. You can chat us up so that we can make the services seamless for you. So once more, thank you for joining us. We are grateful, and we hope to see you in the next episode that's coming up on the 13th of March. So do well to invite your friends, those that you want to participate, you can reach out to them. And I've also pasted a link for our WhatsApp group. We have a WhatsApp group that we post information about the activities we have coming up. So kindly click on the link and join the group. Thank you so much, and we hope that we do more of this together. So do have a wonderful weekend. Thank you so much.